Well, thanks for the opportunity to start this symposium on osteobiologics. And I'm going to talk about the drivers of spine fusion, and specifically focusing on instrumentation and also the interplay between our instrumentation and our osteobiologics. By way of disclosure, I've received fees as well as royalties from companies that are involved in the sales and marketing of implants as well as osteobiologics. I'll try and present this without bias. So I think we recognize that there's a real synergy between biomechanics and osteobiology, and that synergy can really be captured in the field of mechanobiology. I'll talk a bit about rigidity of our implants and of our constructs, and ranging from semi-rigid constructs through multi-rod, very rigid constructs. I'll also talk a bit about interbody devices, and Dr. Shu's going to talk about that a bit more later. And then finally, optimal biology, and Dr. Wong is going to address that a bit further as well. So what are the real drivers of spine fusion? I think we can't really consider implants and osteobiologics separately. It's sort of like bricks and mortar. And to get a sustainable, lasting structure, we've really got to have both of these working in synergy. And I think our bone graft materials really provide the substrate upon which mechanobiology has its transduction effect. And our instrumentation fundamentally starts off with stabilizing that functional spinal unit and creating a mechanical environment that permits new bone formation. And we've really got to look at some of the rates and reasons for implant failure, including loosening and breakage. Fundamentally, our goals in spine fusion are to stabilize one or more functional spinal units, to realign the spine, and importantly, to maintain that realignment. And it's not going to be maintained in the absence of a solid arthrodesis. So the clear solution to this is a stable, solid arthrodesis. And evaluating this can be challenging, and I've really found some of these kinematic studies to be quite useful to look at a solid fusion in this case compared to a fusion which has got abnormal motion and pain in this case. Just to start with a bit of history, I think it's important to recognize these pioneers. So Dr. Albee and Dr. Hibbs, both in New York, for different reasons, were fusing spinal deformity and using bone grafts in the absence of instrumentation. Harrington then introduced instrumentation, at least initially, without actually a fusion. I think it was John Moe who deserves much of the credit for combining the concept of instrumentation and fusion effectively to really get a durable construct with regard to reconstruction, at least in the spine with deformity. So combining instrumentation and arthrodesis certainly is important. The biomechanics, I think, are fundamental to understanding this, and a favorable environment for osteoneogenesis or for new bone formation involves stability. A stable construct with limited strain is going to really allow for direct bone formation. When there's more motion, indirect bone formation. Load sharing is very important in the mechanical transduction upon our bone graft material, especially on cells specifically. We need apposition between the end plate and our bone graft, and fundamentally limiting strain. Strain on the implants certainly can lead to loosening, and strain on our bone graft can really induce a more of a fibrous or chondroblastic response rather than an osteoblastic response. And these are just two examples. This example on the left was a well-known minimally invasive surgeon who did this interbody graft that's nowhere remotely in contact with the end plates, but decided to publish that. And then on the right-hand side is a case I revised recently of loosening of S1 screws in a patient who clearly was left in malalignment, had a lot of strain on those S1 screws, and this is one of the reasons we use pelvic fixation in most of our longer constructs. So this biomechanically, regardless of what might have been used for bone graft material, this was predisposed towards an early failure. So the mechanical biology really, again, the construct of the spine has an important impact on the biomechanics on bone graft, both in the inner space as well as in the posterolateral space. And we recognize that stress and strain on mesenchymal cells can have a major impact on that differentiation. So mesenchymal cells differentiate into bone versus cartilage versus fibrous tissue, proliferation of these mesenchymal cells, as well as the production of an extracellular matrix. And I think Jill Helms, this work was done when she was at UCSF, and she really gave a nice description of this, looking at intermittently imposed loading on regenerative tissue. And she showed that when there's low or moderate stresses and strains, then that really stimulated an intramembranous or a direct new bone formation. Whereas environments with poor vascularity, environments where there might be a bigger gap, environments where there's high tensile strain, this really stimulated an environment for cartilaginous proliferation and for fibrous tissue. So this is a really foundational paper, I think, with regard to the mechanobiology of new bone formation. And again, this applies another, I think, classic paper here about the importance of stabilization in spine fusions, as well as effective decortication and apposition of fusion surfaces. I think Scott Bowden's work with rabbits really gave us a great insight into histology here and looking at the uninstrumented rabbit fusion, recognizing that there's a coupling of both intramembranous as well as endochondral bone formation that's probably related to gap size as well as motion. He also emphasized the importance of decortication for getting an effective fusion. So it brings up the question of what is the ideal construct stiffness. And clinically, we recognize the difference between a titanium rod and a cobalt chrome rod. The stiffness of the rod has a major impact in our ability to do things like cantilever techniques. It also has an impact on the maintenance of our correction as well over time. And we recognize some work by Charlie Johnson shows pretty convincing evidence that the increased construct stiffness is associated with a better fusion mass. And he really didn't show any evidence of stress shielding in his canine model. Another classic work, this is more clinical, by Dr. Zadeblik in Wisconsin, suggests again that more rigid constructs are more likely to fuse. These were some classic papers. But Mark Asher also suggested that this might not be a consistent effect, and that indeed in another canine model, there might be some delay in fusions in our more rigid constructs, and this might be related to stress shielding. And this brings us to the work of, to the recognition of stress shielding and Wolff's law, and the fact that in many constructs where the rigidity might be excessive, we might be inadequately loading our bone graft. So what's the appropriate stiffness for our constructs to get a fusion? And we recognize with regard to some semi-rigid constructs that peak rods in this systematic review have some theoretical advantages with regard to interbody load sharing, perhaps reducing stress at the bone screw interface, and maybe reducing the mobility at the adjacent segments. But also some real disadvantages, and in the clinical studies, some evidence of screw loosening, wear debris, and variably reported fusion rates in a systematic review. Similarly, the Denesis, this was work done out of Los Angeles, and Jeff Wong was involved in this, looking at 21 different studies in a comprehensive review of the literature. And in this instance, the suggestion here is that dynamic stabilization has similar complication rates to rigid instrumentation, and perhaps a slightly lower incidence of adjacent segment degeneration and adjacent segment disease. Well, what about troubles with our rigid constructs? And we recognize this work from the ISSG that implant failures are common. And looking at radiographic and implant-related complications, fully 30% of patients undergoing multi-level fusion for deformity had such complications, half of whom required reoperation, and half of those complications indeed were for rod breakage. Especially in our three-column osteotomies, this is a real problem, where about 40% of patients with three-column osteotomies had implant complications. And this is perhaps a construct that we could have predicted a problem with in a case done locally in my area, where behind a three-column osteotomy that wasn't fused circumferentially, the rods broke. So this introduces the role of multi-rod constructs, and Munish Gupta and a group in St. Louis described some of the different constructs that are done with multiple rods. And now this is much more commonly on the right, the type of a construct that is characteristic of my multi-level deformity, multiple points of pelvic fixation, typically 4 or more rods across the 3-column osteotomies at least, and a much stiffer construct. And this meta-analysis suggests that at least in our early experience with multiple rods, this results in less rod breakage, less pseudoarthrosis, less revision surgery, and actually better clinical outcomes. There is some concern about higher caudal screw loosening, and importantly, so far, no difference in PJK rates. Well, what about, we focused on posterior stiffness, what about our inner body implants? And there's a broad spectrum from bone to synthetic devices of choices we have for the inner body space. And the importance of end plate preparation is a big part of this. We heard this in the last paper as well. So the distinction between failure and success of fusion is a load transfer onto the material, load transfer between bone and our fusion material. And a big part of this has got to be end plate congruity. And we recognize that indeed, despite material, subsidence is actually defined mostly by the contact area between the end plate and the implant. So whether it's PEEK or titanium or some other material, the modesty of the material doesn't matter as much as the contact area. And indeed, good contact area can also reduce strain on our posterior rods and reduce implant failure. In terms of osteobiology, we recognize that certainly titanium, nanoporous, and microporous titanium may create a biological environment that's more favorable to bone formation. And indeed, in some instances, actually upregulate some bone-forming cytokines. And we showed with the group in Colorado State that indeed, compared to smooth PEEK, porous surface did better with regard to osteointegration. So we've got a broad spectrum of options to choose for interbody material, and right now I think what's really needed is comparative clinical studies. Similarly, a broad spectrum of materials that we can use for our fusion, from autograft through allograft through synthetic matrices. And again, what's sorely missing is comparative studies to look at effectiveness. So I'll conclude with recognizing there's a real synergy between our spinal constructs and osteobiologics in trying to gain an effective spinal arthrodesis. I think decision-making with regard to our construct design, as well as our bone graft choices, is often made with incomplete data. And what we really need, I think fundamentally in this area, is better comparative clinical studies, so that'll really guide a better evidence-based approach to appropriate construct designs and appropriate choice of bone graft. So thanks for letting me lead this off.